Welcome back in a video discussion of DNB OSCE examination pattern for the DNB practical examinations. So in practical examinations, OSCE is a very important part, and more or less for different specialties the questions patterns are same. So we will try to discuss the OSCE examination pattern. We will try to understand the question models, and we will have a look how to answer these OSCEs. Alright, so let's start. I'm Dr. Ravi Kumar Sharma, consultant, critical care consultant and pulmonologist working here at Bhopal. So let's start. So in this way we are given a case scenario with some associated radiographic or CT findings. Sometimes instruments may be there also. So first we have to read very carefully the clinical description of the patient or the case scenario and look for the radiographic finding, and then we have to answer. Alright, so coming to here, the OSCE 1, a 55-year-old male coal miner for last 3 years complaining of dry cough, shortness of breath, mild expectoration for 6-month duration. On examination, he is afebrile, heart rate is 106, blood pressure is 114/74, saturation is 93 at room air, and jet deformity in the finger with ulnar deviation was noted in both hands. On auscultation, bilateral basal capsule present, and this is the X-ray finding. Here we can see bilateral lungs lesion. Alright. So question number 1 is, what is the diagnosis? Number 2, what is the name of the lesion shown in the chest X-ray? What is the most serious disease this patient can develop in the later life? And which cancers are at risk in this patient? So these 4 questions we have to write, and this is the clinical scenario. So questions are very specific. So yes, answer should be yes to the point and very specific. First is Kaplan syndrome. Number 2 is that these lesions are called Kaplan lesions. The most serious complication this patient can develop is progressive massive fibrosis, and that they are at risk for gastric carcinoma. So in this way we have to be answered, and that answer should be from any standard book we are going through, we are reading. Alright. Coming to the OSCE 2, a 60-year-old stone mason working for building construction company for last 25 years admitted in the emergency room with shortness of breath for 3 days. On admission, he is a tachycardia, heart rate is 120, blood pressure is 130/84, saturation is 80 at room air, RBS is 10145, temperature is 98 degree Fahrenheit, ECG showing sinus tachycardia, D dimer normal, chest X-ray done. Chest X-ray, here we can see there is a lesion in the both lungs, if you see here. Alright. So what is the diagnosis? What are the 3 types of the disease, and what are the 2 important complications of the disease? So we have to catch the important points. Old stone mason working. Stone mason, okay, working in a building construction, presented with a hypoxia, and this is the clinical presentation. So it is the case of acute silicosis. And what are the types of silicosis? One is acute, second is accelerated, and third is chronic. And the complications he can develop is tuberculosis and pneumothorax. So in this way we have to be very specific about answers. Again coming to OSCE 3, here we can see a 41-year-old lady, female, recently joined as a school teacher, where she used to old cemented background with chalk, complaining of cough and wheezing for last 15 days. Symptoms are worsened when she returns from the school and usually gets relief on the weekend and holiday. There is no other medical condition and no similar history in the past. No family history of such diseases. She was advised for self-PFR monitoring at home and has shown in the graph. This is the PFR monitoring she was advised, and when she is off work, here we can see this is the off work. When she is at work, these are the upper part. We can see that most of the days in the weekdays, Monday, Tuesday, Wednesday, there is a significant PFR variation. This is the peak, this is trough, peak, trough. So this is a significant PFR variation. But on Saturday, Sunday, there is no significant PFR variability. Alright. So we have to answer based on this clinical information given to us. What is the diagnosis? What is the most likely sensitizer in this case? And we have to enumerate the 3 important steps in the management of this case, and we have to write the formula of PFR variability and its role in the diagnosis of asthma. So from the history, from the clinical presentation, from PFR variability, we can say that this is the case of occupational asthma. Alright. So now answer will be occupational asthma. Number 2, sensitizer in this patient, in this teacher, is chalk dust. Alright. And the 3 important steps is, first is very important, removal of the sensitizer, the thing which is causing the problem for her. There is chalk dust, we have to remove that one. Number 2, if possible, change of the occupation. And if that is not possible at all, then we have to look at preventive measures in the form of, she can use a mask, or it is changed to electronic board for teaching. And somehow we have to adjust we have to remove the sensitizer in the occupational asthma. Alright. So formula for PFR variability is PFR at night minus PFR in morning divided by half of the PFR at night plus PFR in the morning multiplied by 100. And PFR more than 10% is the consistent with the diagnosis of asthma. Alright. So in this way we have to answer our questions in the OSCE, because it's a very time bound, it's a very limited time is given to the each OSCE. So we have to be very specific. Coming to question 4, it is a clinical scenario given a 35-year-old man presented with his primary care physician for numbness and weakness in the left lower extremity. He has also noticed skin changes in the affected leg. His medical history is significant for asthma treated with albuterol. On physical examination is significant for 3/5 strength throughout the lower extremity and decreased touch sensation. There are cutaneous and subcutaneous nodule. Lab findings are significant for positive MPO ANCA and P-ANCA antibodies, and a serum eosinophil level is 8000 per microliter. So the clinical scenario here is patient is having asthma, some looks like a vasculitis lesion, and he is a positive C-ANCA, MPO ANCA and P-ANCA antibodies with serum eosinophil is very high. So what is the most likely diagnosis? Enumerate the 6 criteria used for the diagnosis, and what is the mainstay of treatment, and what is the serious renal complication of the disease. So 4 questions are asked on this clinical scenario. So what is the case? This is the case of EGPA or eosinophilic granulomatosis with cholangitis. ACR criteria for EGPA diagnosis, 6 criteria is: first is asthma, eosinophilia more than 10%, there may be neuropathy, mono and polyneuropathy, pulmonary infiltrates, there may be non-fixed or paranasal sinus abnormality, and extravascular eosinophils. We have to add all these 6 criteria. Mainstay of treatment is corticosteroids, and the renal complication this patient can develop later in his life is focal and simultaneous necrotizing crescentic glomerulonephritis. So this is where we have to be very specific about our answers and regarding the answering in the OSCE. Hope this will be helpful for the aspirants who are going for the DNB practical examination, and prepare yourself accordingly. Alright, thank you so much. So if this video is helpful, share among your friends who are going to give the exam, and also share your comments, your suggestion in the comment box. If you want some topics to be discussed, we can make on the topic for that, for the easy understanding. Thank you for watching.